Welcome to Optimum Life Re's module on chronic pain and opioids. I'm Minas Joannides, the Chief Medical Director at Optimum Re, and we're going to have a presentation concerning chronic pain and the medications used to treat it. First, we want to talk about acute pain, which is normal response to an adverse chemical, thermal, or mechanical insult associated with surgery, trauma, or acute illness or injury, and it results from the activation of pain receptors at the site of tissue damage. It plays a vital survival role for individuals because it provides a warning that something is wrong and prompts remedial attention. So acute pain is referred to as having biologic utility. In other words, it serves a purpose for the individual. We want to contrast that with chronic pain, which is pain that persists beyond the normal time of expected for healing, and it's caused by central neuroplastic changes in the brain and spinal cord. So there are actual changes in the central nervous system, along with a complex interplay of emotional, psychological, and social factors that contribute to an individual's worsening ability to function, and it affects their life. It's persistent underlying discomfort punctuated by acute flare-ups that can be short-lasting, like minutes to several days, and leads to impaired functioning. These episodes do not reflect new tissue injury or damage, but are almost always self-limiting. And chronic pain has no biologic utility, contrasted with acute pain, and offers the individual little protection from further injury. Here's a slide that shows the chronic pain ratings in the Optimum Re manual. And let's go through this so you have a better understanding of what we're going to be talking about today. So there are very unfavorable and unfavorable characteristics, as well as favorable characteristics when looking at an applicant who has chronic pain and may have been treated with opioid medications. So let's go through these. Very unfavorable characteristics leading to a decline of the application of the applicant would be any evidence of polypharmacy, the use of multiple pharmacies, repeated mentions of lost prescriptions, any physician expressing concern or suspicion about pain medication usage, or increasing dosage required to treat chronic pain. Favorable characteristics would be localized pain to a specific location, such as an arm, leg, or area of the back. Onset of pain is recent, less than 2 years. No depression, or the depression is only mild. No past recreational drug use. Good physical and emotional, functional ability. Good family support. Managed and prescriptions written by one physician rather than a multitude of physicians prescribing pain medicines, low dose medications, and no concerns about pain requiring increasing medical adjustments. Unfavorable characteristics in order from highest to lowest concern would be any evidence of fentanyl or Suboxone use, and we're going to talk about those drugs in a little bit. Morphine use, the addition of benzodiazepines on top of opioid use. Benzodiazepines would be drugs like Xanax. Any additional alcohol misuse or abuse, past recreational drug use. Multiple physicians, including a pain specialist treating the pain with medications, long-standing pain, diffuse pain, depression, and no evidence of non-drug pain management. In other words, there's no evidence that the patient is trying to be weaned off of drugs in order to relieve their pain. Limited physical and functional ability, limited ADLs. The applicant is disabled, socially isolated, or requires the use of a cane or walker. And There are many different treatment options for chronic pain, which you may see listed in APSs. The applicant may be going for chiropractic care, getting massages or physical therapy, acupuncture, biofeedback, using a TENS unit, transcutaneous electrical nerve stimulator. Hopefully they're on non-opioid type medications for pain, Tylenol, non-steroidal, anti-inflammatories like ibuprofen. Maybe they're receiving nerve blocks for a specific area. They've used corticosteroids for local areas of pain. They may be on narcotics, which we are going to talk about, including all the opioids. Anticonvulsants may be used, such as gabapentin or Lyrica, and the applicant may be going for behavioral modification therapy. So I want to mention, sometimes it's confusing when people are talking about opioids versus opiates. What's the difference? So opiates are natural occurring opioids, such as morphine, heroin, or codeine. So if somebody says they're talking about opiates, it's those types of medications. Opioids is the all-inclusive word, which includes opiates and everything else. So these natural opiates are included in opioids, as well as semi-synthetic and synthetic opioids. We're going to talk about these as well. So the word opioids covers all these drugs, whereas opiates are only the naturally occurring one. Now, fentanyl, unfortunately, the U.S. has a rash of illicit fentanyl coming into it from other countries, the drug trade, and it's being used, sold on the street. It's 50 times more powerful than heroin and 100 times stronger than morphine. So it's a major contributor to fatal and non-fatal overdoses in the United States, and a dangerous drug. Just to give you an idea of the power of fentanyl versus morphine, fentanyl is so strong that it's just small, tiny doses equal, a regular dose of morphine. And we're going to talk about the units, which is very important when you talk about fentanyl, because very tiny doses have a powerful effect. And later we're going to talk about the opioid oral morphine milligram equivalent, which is MME. And the drugs we're going to talk about today, we're going to show you how you can convert whatever drug you're speaking of into a morphine milligram equivalent as a standard. So fentanyl, like a fentanyl patch, which can be left on for 24 hours, is a powerful drug. Maximum morphine equivalent dose. So as I said, we're going to show you how to convert all the opioids into a morphine equivalent dose. And when you do that, the reason we're doing this is so that we can assess what is the total dosage that an applicant might be receiving when you look at the APS. And greater than 50 milligrams of morphine a day is a definite concern. And even more worrisome are dosages that are greater than 90 milligrams of morphine equivalent per day. So keeping those in mind, if you're able to convert, and I'll show you how to do that, whatever drug you're looking at on an applicant, the 50 and 90 are kind of key markers to keep in mind in terms of morphine equivalent dose. So how do you do that? So this is a morphine milligram equivalent calculator, which you can find on the internet. And you can plug in the name of the drug, the dosage in milligram per dose, and then how many doses is the applicant taking per day. And you calculate out what is the morphine milligram equivalent using this kind of a calculator? Is it less than 50, hopefully? The smaller the number, the better. Or is it a larger number, say greater than 90, which would be very worrisome? So give you a idea on this chart as to how these strengths compare. Let's look at, I've highlighted in yellow, morphine, and then in parentheses, milligram, and then 1 to the right. So that's basically our standard reference point. So 1 milligram of morphine is our base, kind of like a standard mortality would be 100%. That's basically the same idea with 1 milligram of morphine as our basic standard. Now, I've also highlighted for fentanyl, what those, the way those drugs are prescribed, or if they're used illicitly, those are in mcg, which is in microgram, or a smaller amount. And those, whether it's the film, the nasal spray, the patch, or whatever, of fentanyl, you can see very tiny amounts in micrograms, not milligrams, but micrograms, and that equals 1 milligram of morphine. So super tiny doses of fentanyl equal 1 milligram of morphine. And to compare other drugs, if you look below the morphine that I highlighted, say oxycodone, which is 2 lines below, that has 1.5. So 1.5 milligrams of oxycodone equals 1 milligram of morphine. So it gives you a relative idea of how powerful the drugs are compared to morphine. So I typed into ChatGPT what are morphine milligram equivalents, and it gave me back that they are a measure used to standardize and compare the potency of different opioid medications. It allows healthcare professionals to assess and monitor opioid dosages to minimize the risk of opioid-related overdose and misuse. MME is based on the relative potency of opioids compared to morphine, which is considered the standard reference. And by converting different opioids to their equivalent morphine dosage, healthcare providers can make informed decisions about opioid prescriptions and ensure appropriate pain management while minimizing risks. So it's very important to use this as a standard so different physicians can all understand, what the dosage that they're providing their patient is in a morphine milligram equivalent. And physicians like myself that have DEA licenses in order to prescribe opioid medications, you have to apply for a license with the DEA and pay your dues in order to maintain your license. Now there are actually, you have to get continuing medical education as prescribed by the DEA, and most states actually have similar requirements for doctors to be continually learning about opioid use, and hopefully this will help stem the opioid epidemic, which has taken over the United States with outcome for so many people that were addicted to the drugs. So in our Optimum manual, the Life Manual, these are the ratings for chronic pain. And you can see it's divided into mild, moderate, and severe. It has what are the unfavorable characteristics, and those people we would decline. What are the mild, moderate, or severe characteristics, and what rating would we apply? And then if depression is also present, what are the additional ratings, or what would require a decline for that applicant? So you can refer back to our manual to get these ratings. So I have a case history for you. Case number one, 51-year-old male with severe chronic back pain with multiple back operations following a work-related accident. He's been on disability for the last 5 years. His family doctor prescribes methadone. Now, we haven't talked about methadone yet, but we will. But you probably have an idea what methadone is. He uses that on a regular basis. His back pain doctor injects him with medication to control the back pain. He smokes tobacco and attends AA for his past alcohol history. He has severe obstructive sleep apnea with a BMI of 40. So if you put all of this together, what would you consider his rating likely to be? So I think he hit a lot of the boxes for high risk, right? So he's on disability, he's had chronic pain a long time, he's requiring methadone, which is not the typical drug one would use for treating chronic pain for a limited amount of time. He requires additional injections, he smokes, he had alcohol issues in the past, he's overweight with sleep apnea, and the outlook for him does not appear to be good. So this rating would likely be unfavorable, and we would likely decline him. Opioid drug addiction treatment programs. So these are drugs that are used for people that have had difficulty with opioids in the past. So buprenorphine, Suboxone, which is a combination of buprenorphine and naloxone. A different name is naltrexone, so that's different than naloxone. So remember the trex to distinguish those two. And then methadone, which we just noted in our last case, are used in drug addiction treatment programs as well. And then separated from that group, I have the drug naloxone, which by itself can be used in a different way. So if you see the four drugs at the top, that's a concern that this particular applicant may have had problems in the past with drugs such as opioids. So you're going to want to screen those cases very closely, with a rare exception, which I'll mention in a little bit. Naloxone is completely different, but it is part of Suboxone, so that's why I'm also mentioning it on this page. So Suboxone contains both buprenorphine and naloxone, and it is used, as I said, in people that may have had a problem with opioid addiction in the past. Methadone is used in opioid use disorder. It's approved for pain management as well. It's a long-acting opioid agonist, which means it has activity on the receptors. It reduces opioid craving and withdrawal. It blunts the effects of other opioids. Naltrexone, remember the Trex, T-R-E-X, it blocks the effects of narcotics. It eliminates the high feeling of opioids, and it has itself no narcotic-like effects in contrast to methadone that we just mentioned. And what you may see in some applicants is doctors are using low-dose naltrexone in off-label type uses. And this is a report of using low-dose naltrexone as a novel anti-inflammatory treatment for chronic pain. So in contrast to being used as an opioid addiction drug, it may have these other uses in low doses. So if you see this in an applicant's APS mentions as naltrexone being used for something that doesn't appear to be related to any past drug history, that may be the case. So let's compare these two names again. So in case you see them in an application, you don't get confused. Naloxone and naltrexone are both opioid blockers. But naloxone is a fast-acting medication that reverses the effects of an opioid overdose. Naloxone is also called Narcan. Naltrexone doesn't work in overdose situations. So if somebody's been overdosed on opioids, you give the first one, the naloxone or Narcan, not naltrexone. And naloxone is completely safe. There's no risk to administering it, using it, or having it. So there's no federal standing order authorizing access to the use of naloxone, but there are in every state standing orders to allow any individual to obtain naloxone from a pharmacy. And it looks exactly like what I have pictured at the bottom. It's administered nasally. If you suspect that somebody has overdosed on opioids, you would waste no time in giving them a nasal spray of Narcan. There's no downside risk. It doesn't do anything negative to the body. It doesn't have any narcotic in it. It's completely safe. So you can administer it once, twice, or as many times as necessary if you suspect that somebody has overdosed on opioids for whatever reason. So if you see this on an applicant's application, don't take any adverse action for Narcan or naloxone. And actually, we can get into problems if you deny coverage or rate or do anything else for someone who has or in the past or currently has a Narcan prescription. So it's completely safe. You don't have to go digging around in their past history, see if they've abused drugs in the past. So Narcan is acceptable and should not be considered in any way a negative for somebody's application. And it also works on dogs. So if dogs happen to get into someone's opioid supply and you see the empty bottle or the tablets on the ground and the dog is lying unconscious next to it, you can administer Narcan nasally just like you would in an individual, and you can administer it as many times as necessary to revive the dog. You may be interested in how long do opioids last in someone's system? And the answer is if you use 3 days, it's probably correct for whichever opioid you're talking about. So just kind of keep that in the back of your mind. 3 days is basically the right answer for how long does it last. So long time. You may do on an applicant a drug screen, a more in-depth drug screen that screens for opioids. And you may find that more than one opioid medication pops up as positive. So your first suspicion is that they're taking more than one opioid drugs, right? Which would be concerning, worrisome. However, what you should realize is that some opioids metabolize to other opioids that are being tested in the drug screen. So, for instance, if you saw that oxycodone, which is the third from the bottom, was positive on the drug screen, and also oxymorphone was positive on the drug screen, that's because oxycodone metabolizes to oxymorphone. So both drugs could easily be present on a drug screen. It doesn't mean you have to go deep diving in the applicant's history to see if two different doctors are prescribing two different drugs. So hopefully that's helpful. So using Chat GPT again, I mean, we want to stay on the cutting edge, right? I pardon my poor grammar in the question to Chat GPT, but I said, what is OxyContin metabolites? And I then corrected it, but I got a different answer when I used what are the OxyContin metabolites. So I went with the bad grammar question and I got a better answer. So OxyContin, known by its generic name, oxycodone, has a primary metabolite of oxymorphone. So as I said, both may be present on a drug screen, but it doesn't mean they're taking two drugs. So I have another case for you, case number 2. So a 61-year-old woman is seeing her holistic medicine doctor as part of her medical care. And as part of her health regimen, the holistic doctor has prescribed a very low dose of naltrexone for her suspected fibromyalgia. You are suspicious she is on naltrexone for prior opioid abuse, which we said is one of the reasons people would be on naltrexone. What should you do? Well, we just said some doctors are using naltrexone in low doses for off-label reasons, just as this article had said. So probably don't need to call in the SWAT team to go for a deep dive into her the past 20 years of her life, looking for drug issues. So probably no problem. Case number 3, a 48-year-old woman with chronic pain has been using opioids for several years, and the morphine milligram equivalent is approximately 70 milligrams per day. We said 50 was already starting to be worrisome, so this person is up to 70 a day. That's a lot. She also uses Xanax for anxiety. So now there's the combination, the synergistic effect of benzodiazepines and opioids. Not a good combination. She goes to she's been referred to a pain specialist, but she prefers just to continue the opioids. So somebody is writing prescriptions for very large doses of opioids for this person. And she also dabbles with magic mushrooms for depression. Now, we have looked at people that use magic mushrooms separately, not related to using them along with opioids. And magic mushrooms may provide, under supervised care, our thought now maybe to offer some hope for people with depression. And when used appropriately or managed by people that are expert in the field, magic mushrooms may be something new to look forward to in treatment of depression. But it appears that she's just dabbling on her own. We don't know doses. We don't know what dabbling means here. And it's in combination with a variety of other features which are concerning, that she doesn't really want to have a pain specialist assisting her. She just wants to continue her opioid. She's on a large dose. She's also taking benzodiazepines. And she's been on the medicines for several years. So again, not a good risk, though you probably would not want to take this person. So that's because her morphine milligram equivalent dose was greater than 50, which we said was a concern, right? We saw this slide before. Now, I want to just mention that I've gotten some slides from Change That Matters. So these are all attributed to this group. And you can go to this website and get all their slides on Change That Matters. It's a group that tries to help people with chronic pain understand what the characteristics are of chronic pain and how to move to a better place in their life that hopefully is free of opioids and uses other measures to treat chronic pain. So that's why it's change that matters. So there's a series of slides that they have, and so this is all their material. But I just thought I'd show you some of them. So if you go to this website, you can see what they offer and go from there for your own. Maybe you want to do a seminar in your own company on chronic pain and the related field of opioid medication and how to deal with that. So they have definitions of pain, just like we started with at the beginning of this webinar, with acute, subacute, and chronic, so you can get the definitions. And this is the slide I started with at the beginning of the talk, which talked about acute pain having biologic utility, or it's useful. Chronic pain that we talked about, which does not provide any biologic utility. The prevalence of chronic pain in the US, and it's not just the US, but other places have issues with chronic pain and medications that are used or overused or abused to treat chronic pain. Co-occurring concerns, and what else happens in the person's life in addition to the chronic pain, which makes their life less enjoyable and more difficult to live in. What are interventions that people can take actions in order to help with achieving a opioid-free treatment program for chronic pain? So realistic expectations and goals, relaxation training, cognitive behavioral therapy, abbreviated CBT, if you see that in an APS, activity pacing, and then family interventions to help the person improve. Talks about relaxation training, how to hopefully, perceive the pain in different ways so that you're able to function in society better, have a better life. And cognitive behavioral therapy, or someone to possibly help you think about, how can I deal with my pain in better ways rather than using maladaptive thoughts and opioids in order to treat it. Setting pain reduction goals. What am I going to do today to help relieve my concern about my pain, which never seems to go away? So, what actions can you take that might be helpful rather than just taking another pill? So that completes our talk today. I hope it was useful. If you have any concerns about chronic pain or opioid use for an application, please let us know if we can be of any help. If you'd like to hear more about this topic or other topics that you're interested in, we'd be more than happy to consider providing a webinar on that subject. So let us know at Optimum if there's any other things that we can assist with. And that completes our talk for today.